this session is like revising all the important points in 1 hour, right? So the very first important segment is of course the bony tumors and Codman's triangle. The moment you see a triangular appearance like this is the Codman's triangle and this is the periosteum. Clear? So if you see appearance something like this Codman's triangle has to be remembered for osteosarcoma. But again I say it is non-specific. If you see Codman's triangle, it is not the case that it will be osteosarcoma. It can be some other condition as well. But yes, from FMGE point of view, I think Codman's triangle has to be related with osteosarcoma. Then next important thing is the sow bubble appearance, and this is very characteristic of giant cell tumor or what you call osteoclastoma, right? So this is the sow bubble appearance for giant cell tumor, clear, or osteoclastoma. Then now this is epiphyseal lesion, okay? This is in epiphysis. Then extending on to metaphysis, of course. This is a metaphyseal lesion, right? So locating the area of the bone will also help you sometimes. And this is diphyseal in the shaft. And if in the diphysis you can see the onion peel appearance, straight away you can mark your answer as Ewing's. Clear? So this is the onion peel appearance. Then related to vertebral hemangiomas, if you are looking at the vertebral body from side, you will see appearance something like this. Okay, so these are vertebral hemangioma, linear striations. But if you take a transverse section of the vertebra, if you see the vertebral body like this, you will see multiple polka dots. Clear? So this is the polka dot appearance on transverse section. Clear? And these are the linear striations on lateral view, right? So condition is same. It is just the view which is different, and therefore we are getting different findings. So linear striations, vertebral hemangioma, polka dot, vertebral hemangioma. Only the views are different. Then ground glass or cotton wool has to be remembered for fibrous dysplasia. But what is more important for you to remember in fibrous dysplasia is the Shepherd crook deformity of the proximal femur, right? So this is proximal femur and it bends to form a Shepherd crook deformity. Now this has been asked many number of times, so please be perfect with that. Then sunray, yes, this is very characteristic for osteosarcoma, right? So again you can see that the tumor is within the metaphysis. So this is a metaphyseal tumor, and sunray appearance, this is osteosarcoma, and this is actually calcification along the blood vessels. Clear? Then some terminology. There is one type of fracture which is exclusively seen in children, and here the one side cortex bends but the other side cortex breaks, right? So this is an, you can say the fracture line is incomplete, and this is similar to like if you try to break a green stick. So this fracture is also known as green stick fracture, right? And this is seen only in children, not in adults. Then base of thumb, if you see a linear fracture line which is going into the joint space, so this is the intra-articular fracture base of first metacarpal, and this is the Bennett's fracture. But if this fracture line also extends outside, or that is extra-articular, and it gives rise to a like T-shaped or Y-shaped configuration, then it becomes a Rolando fracture, right? So this is very important. Bennett's, there is just a simple fracture line, but in Rolando's it can be either Y or it can be T. Clear? So there is extra articular extension. So this is important. Now the fracture of radial styloid, that is known as Schaufer's fracture. Clear? So this is the radial styloid, right? So this is the Schoffer's fracture. Clear? So fracture of radial styloid, it has to be, this is radial styloid. This is Schoffer's fracture. Chauffeurs are actually drivers of the car. Then Jefferson, how to remember it? Remember Sun 1. So this is cervical vertebra 1, which is like ring shaped, okay? And this is actually the burst fracture of cervical 1. Okay, so that is Jefferson. Bimallular, if both the malleoli are fractured, that is the medial malleolus and the lateral malleolus. If both the malleolus is fractured, this is bimallular. If there is fracture of all the three, that is medial, lateral plus posterior, it becomes a trimallular, right? So bi is 2, tri is 3. Now bimallular is also known as Spott's fracture, and trimallular is also known as Cotton's fracture. Then in Monteggia, there is fracture of proximal ulna, and there is dislocation of the superior radioulnar joint, which can also be mentioned as dislocation of head of radius. Clear? So here you can see this is ulna. Clear? This is all ulna. So you can see there is a fracture in the ulna, and there is outward movement of the head of radius. So this is the head of radius here, and you can see that the superior radioulnar joint is disrupted. So this is Monteggia. In another variety, there is fracture of radius. Clear? So this is radius, and there is disruption of the inferior radioulnar joint. So this is Galeazzi. So in Galeazzi, there is distal radius fracture with distal radioulnar joint dislocation. Then burst fracture is a compression fracture of vertebra when a person falls from height. Nightstick fracture is isolated fracture of shaft of ulna. Like if someone tries to beat you with a stick, the very first reaction will be to protect yourself. So the ulna is exposed and the assault is over. Ulna, so it fractures. Boxer's fracture, this is neck of 5th metacarpal, and Jones fracture is the base of 5th metatarsal, right? So this is in hand, this is in foot. Clear? So 5th metacarpal, 5th metatarsal, Boxer and Jones fracture respectively. Now stress fracture, which is also known as March fracture, because it is specifically seen in army recruits. So this is March fracture, or a kind of stress fracture, usually involving the 2nd or at times 3rd metatarsal. Okay, so in foot, and this is known as March fracture because the newly recruit army or police recruits, they have to do a lot of march pass. So at times the bone can fracture. So you can see the fracture here. Now, irrespective of the age and gender, clavicle is the most common bone to fracture in body. So if there is a question, most common bone fracture in the body, answer is clavicle. If there is a question, most common bone fracture during birth, you have to answer it as clavicle, right? Clavicle belongs to the class of long bones, but it differs in some terms. Like long bones have medullary cavity, but clavicle does not have. Long bones, they lie vertically, but clavicle lies horizontally. Clear? So these are few exceptions of clavicle. Being a long bone, it does not follow other features of a long bone. So these are exceptions. No medullary cavity, lying horizontally. Then pre-patellar bursitis. Pre means before. So there is a bursa before the patella, and it gets inflamed, especially in housemates, and therefore this is known as pre-patellar bursitis or housemate's knee. The other type of bursa which lies below the patella, this is infrapatellar, this is pre-patellar, right? So if there is inflammation of the infrapatellar bursa, the condition is known as clergyman's knee. So just remember these terms: pre-patellar in housemate's knee because of this typical posture so that there is friction over the prepatellar bursa. Then moving forward to dinner fork deformity, that is seen in Colles fracture, because just look at the distal fragment. The distal fragment of the fracture is moving dorsally, so it is going backward over the dorsum, and therefore it gives rise to this dinner fork deformity. Clear? This is seen in Colles. There is one garden spade deformity that you have to remember for Smith. Clear? So garden spade is in Smith fracture, which is reverse Colles. Clear? So remember at least this much. Then some cast and braces. You can see Milwaukee and Boston, these are used for scoliosis because we want to stop the progression of the deformity. Then class holding position is for application of cast in cases of fracture scaphoid. Then for Colles fracture, we give in palmar flexion and ulnar deviation. In some texts you might get the word medial deviation, so it is the same thing. So palmar flexion, ulnar deviation. So this is for Colles fracture. In fracture patella, we apply a cylindrical cast, right? So that is known as tube cast or cylindrical cast, and here we keep the ankle free. Clear? So it is extending up to the groin, and it is just above the ankle joint. It just immobilizes the knee joint. So knee is immobilized only here. So it is just like a tube. So it is also known as tube cast or cylindrical cast. Then cock-up splint, it is used for radial nerve injury. Aeroplane splint for brachial plexus injury. Now these are for nerve injuries. There is one von Rosen splint which is used for developmental dysplasia of hip. There are some more which you should know. One is knuckle bender, which is used for ulnar nerve injury. Clear? So just remember this much as well. There is one Thomas splint, which is used for injuries of lower limb, especially around hip and thigh. Clear? So just to memorize. So these are few important splints. Then coming to neuropraxia. Now here the anatomy is okay, but the physiology is slightly disturbed. It means there is no conduction. But since the anatomy is okay, so we can expect a 100% recovery and therefore excellent prognosis in terms of recovery. So this is neuropraxia. Myalgia paresthetica is compression of lateral cutaneous nerve of thigh, right? And this image is winging of scapula, where you can see that the medial border becomes prominent. Medial border of scapula becomes prominent on pushing action against the wall usually, and this is because of paralysis of serratus anterior, which is supplied by long thoracic nerve of Bell. So here serratus anterior is paralyzed. Clear? Then foot drop, it is usually because of common peroneal nerve palsy. And why we always discuss this question? Because this nerve passes around the neck of fibula. So whenever there is a fracture of neck of fibula, this nerve can get injured and patient will develop foot drop. Not to confuse with wrist drop, which is because of radial nerve injury. Clear? Then in supracondylar fracture of humerus, there is injury to the median nerve, or more specifically one branch of median nerve, that is anterior interosseous nerve. So this nerve is commonly injured, and if we talk about artery, it commonly affects the brachial artery. So brachial artery is commonly injured here, right? So anyway, in terms of nerve, this is anterior interosseous nerve, which is a branch of median nerve. Okay, then tarsal tunnel syndrome, this is compression of posterior tibial nerve, and remember carpal tunnel, which is median nerve compression. Okay, there is one more term, cubital tunnel, and this is ulnar nerve compression. So please make sure that you don't mix up. Now those who tend to forget, you can remember U with U. Clear? Then ulnar nerve, we can see a positive CAR test where there is paralysis of palmar interossei, which are actually adductors of the fingers. Then we can see a ulnar claw hand where there is clawing of only the fourth finger and the fifth finger. The first and second are absolutely normal. So first and second are absolutely normal. So this is ulnar clawing, right? Then in cases of median nerve injury, we can see pointing index. Okay, so this is the pointing index. Then median nerve can be compressed in carpal tunnel. The entity is known as carpal tunnel syndrome. Then we can, in cases of the crutch palsy, is actually the paralysis of radial nerve, and you can see the bilateral wrist drop. Clear? So this is a wrist drop, and especially if a person is using a crutch which is not well padded, it might injure radial nerve. So crutch palsy is radial nerve palsy. Axillary nerve can be injured in two circumstances: either there is anterior dislocation of the shoulder, or there is fracture surgical neck of humerus. Clear? So both the injuries around shoulder. Then moving to carpal tunnel syndrome, we have already discussed that it is compression of median nerve at wrist, right, as it passes through the carpal tunnel, and the conditions which are associated can be remembered by the mnemonic carpal. So C can be compressed median nerve, or you can write cause unknown, that is idiopathic. Clear? So this is idiopathic. Then A for acromegaly, R for rheumatoid arthritis, then P for pregnancy, A for amyloidosis, and L for low thyroid, which is actually hypothyroidism. So these are conditions where we can see carpal tunnel syndrome. Now scaphoid is the only carpal bone which can fracture and which can undergo AVN. So this part, which is appearing more white, has undergone necrosis, and this is known as AVN, that is avascular necrosis, right? So this is the proximal part. So this is one problem which we can see in fracture of scaphoid. So fragment which undergoes necrosis, everyone should mark it as proximal, and the most common site is through the waist of the scaphoid. Then coming to shoulder dislocation, the most common variety is the one where the head of humerus moves anterior to the glenoid and comes to lie below the coracoid, because this is the coracoid process, this is the glenoid cavity. Okay, so this is the coracoid process here, this is the glenoid cavity. So in front of glenoid, that is anterior, and below coracoid, that is subcoracoid. So this is the most common variety, right? Now in posterior shoulder dislocation, of course the anterior one is most common, but in posterior type we can see one electric bulb sign, and this is usually associated with epilepsy or electric shock. Otherwise, in most of the cases we see anterior shoulder dislocation. Now for doing reduction of dislocation, we can use a Cocker's maneuver where the mnemonic is team. So T is for traction, right? E is for external rotation, A is for adduction, and M is for medial rotation. Clear? So that is the mnemonic team for Cocker's maneuver for reduction. Then, so this is the team: traction, external rotation, adduction, and medial rotation. Now, some clinical tests which are done, which are theoretically related to anterior shoulder dislocation, are the Hamilton ruler test, Dugas test, and Callaway's test. So this is again related to placing a ruler. Then this is touching opposite shoulder, right? And Callaway is about the axillary girth, which will increase here. Now, shoulder can undergo recurrent dislocation. It means again and again. So there are two important things. One is Bankert lesion, which is affecting the glenoidal labrum. So there is tearing of glenoidal labrum is Bankert's, and there is indentation fracture over the head of humerus, and that is known as Hill-Sachs lesion. So you can remember H of Hill for head of humerus, right? So that way you can differentiate where we will see Bankert lesion, where we will see Hill-Sachs lesion. Then coming to congenital dislocation of hip, which is not seen in Indian population, it is an entity of Western race. It can be associated with less amount of amniotic fluid, that is oligohydramnios, and the problem is that the acetabulum is not well developed, so the head of femur also slips out. Now we can do two clinical tests. One is Barlow and another is Ortolani. In Barlow, we try to displace the head of femur out of the acetabulum, and in Ortolani, we try to bring it back into acetabulum, and we feel a click of entrance or exit. Now on X-ray, we can see a broken Shenton line. So if you see here, this is the Shenton line which is broken. On normal side, it is a smooth curved line like this, right? So here you can see it is broken, and this is found by the continuous line by the medial side of the neck of femur and the inferior border of superior pubic rami, right? But more importantly, now this is not specific here. This is not a specific finding for DDH. What we can see here, that the femoral head epiphysis will lie in the outer quadrant, upper outer quadrant of a line which is Perkins line and Hingelinus line, right? So outside this, but normally it should be under this. So, and for maintaining that position of head of femur within the acetabulum, we can use a von Rosen splint. So this is the von Rosen splint for developmental dysplasia of hip. The previous terminology was congenital dislocation of hip, that we don't use nowadays. Now hip dislocation, obviously most common is posterior type, and I expect everyone to diagnose it properly on X-ray, because what you need to do, just look at for this lesser trochanter. Clear? So just look for lesser trochanter. And on the affected side, you will not be able to mark the impression of lesser trochanter because there is internal rotation deformity. So this is posterior dislocation, and clinically we will see the classical Fadir deformity here. So this is Fadir deformity. So after injury, Fadir deformity, posterior hip dislocation. So you can classically see the affected knee is touching the opposite knee, then the medial border of the foot is touching the couch. Look at the normal medial border. So this is normal, of course, this is affected or injured, right? And you can see the flexion. So flexion, adduction, internal rotation, that is what is Fadir deformity for posterior hip dislocation. Sometimes the head of humerus, head of femur can perforate through the acetabulum and it can lie within the pelvic cavity. Such a fracture is known as central fracture dislocation, and if we do a per rectal examination, we can feel the head of femur. Then coming to CTV, that is congenital talipes equinovarus, which is also known as club foot because the foot looks like a golf stick. Now it may be idiopathic or it may be secondary. The secondary may be associated with AMC, which is a very severe condition, arthrogryposis multiplex congenita. Now the main thing is treatment. So we will tell the mother to manipulate the feet of the baby after every breastfeed, and once the baby is 1 month old, we will call him for serial corrective casting by Ponseti method. So serial corrective casting, we will apply cast, and the technique we follow is Ponseti method. Now there is one old time surgery, that is PMSTR, that is posteromedial soft tissue release, which was done to lengthen the structures on the posterior and the medial side of the ankle and the foot, and this was usually done at the age of 2 years, but no need for this surgical procedure nowadays if we start the Ponseti technique casting timely. In very elderly patients, you can say maybe more than 12 years, if they come with CTV, then we can do triple arthrodesis. Now triple is 3, arthrodesis is fusion, surgical fusion. So we will fix 3 joints. One is the talonavicular, another is subtalar between the talus and the calcaneum, and the third is calcaneocuboid, right? So these are the 3 joints which have to be fixed. Now please note that we don't touch ankle joint. So ankle joint is not touched here. Then osteochondritis, there is one entity, that is Perthes disease. You can see here, this is affecting the femoral head epiphysis, right? Normally it is such a smooth curved structure. So this is femoral head epiphysis and better evaluated on MRI. There is difficulty in abduction, but adduction as such is unaffected. Similar pathology can be seen in other bones, like for lunate we call it Kienbock's disease. If the same pathology is seen in tibial tuberosity, we call it Osgood-Schlatter disease, and if the same pathology of osteochondritis is seen in calcaneum, we will call it Sever's disease, right? So the pathology is same, the location is different. Coming to bone tumors, for identifying cartilage origin tumors, just look for the word chondro, right? So the word chondro is all suggestive that the tumor is having a cartilaginous component, whereas fully bony origin, you will find the word osteo only, right? So osteo only. Then location wise, from epiphysis, just remember one important entity, and that is giant cell tumor or osteoclastoma. Metaphysis wise, please remember at least osteosarcoma, and of course in terms of diphysis, please remember Ewing sarcoma, which is a round cell neoplasm. So Ewing's sarcoma. So these are 3 important entities which one should know, and most of the time we have question from these entities only. So Ewing sarcoma is diphyseal, especially seen in second decade, that is in the age group of 10 to 20 years. And X-ray we have already discussed, it will show onion peel appearance, and sometimes the condition is confused with osteomyelitis because the age group is same, the clinical presentation is same, that is pain, fever, swelling, and the location, that is the lower thigh. So at times we get confused whether the case is Ewing sarcoma or osteomyelitis. Now there are certain factors which indicates poor prognosis, like anemia, raised WBC, ESR, and raised LDH. Then moving forward to osteosarcoma, it is metaphyseal, and usually the tumor is around the knee joint, affecting mainly the lower end of femur or upper end of tibia. X-ray, 2 important finds, sunburst and Codman's. As I already said, this is non-specific. Clear? And this is a very aggressive tumor, and therefore it will show secondaries in lung. So aggressive, and it means it will metastasize. Clear? And patient might present to us with hemoptysis. Treatment, we can start chemotherapy or limb salvage surgery, but the prognosis is very poor. Patient usually do not survive. Then multiple myeloma, calcium levels are high. Now this is the most common primary malignant bony tumor, right? We can see Benz-Jones proteins, Russell bodies in microscopy, and more characteristically we will see punched out lytic lesions on skull x-ray. So these black dots, whatever you are seeing, these are punched out osteolytic lesions. So moment you see skull x-ray with these punched out lesions, straight away go to multiple myeloma. Then chondroblastoma, it is originating from epiphysis, and we can see dense punctate mottled calcification, right? So what we can see calcification here, and this is of course epiphyseal region. So this is chondroblastoma, and there is a sclerotic rim. Then Page's disease, it usually affects pelvis, tibia or skull, and the only problem is that it can sometimes convert into osteosarcoma. So it is a type of pre-malignant condition. It can convert into osteosarcoma at a later date. For fibrous dysplasia, please remember only one thing: the Shepherd's crook deformity. So the classical, the proximal femur, it curved, so it looks like Shepherd crook deformity. So this is a fibrous dysplasia, right? Then osteomyelitis, it usually starts in metaphysis. So this is all metaphyseal area. And why metaphysis? Because of two reasons: hair pin arrangement, and it's a growing zone, so defective defense. Now presentation is with pain, swelling, restricted movements, high grade fever, and therefore the diagnosis has to be clinical, because x-ray usually does not show any changes in early part of the disease. But yes, we can go for blood culture, which might help us in getting the organism in about 60% of cases. So we can go for culture and sensitivity, but again this is not 100% helpful. The earliest bony change what we can see here is an periosteal reaction. Okay, so this is the cortical line. So this is the cortical line, and this is the periosteal reaction. Clear? So this periosteal reaction takes a lot of time to appear, usually after 10 days, and by that we can't wait till that time. So these x-rays are, in one sense, are of no use to make a diagnosis of acute osteomyelitis. Now in general population the organism is Staphylococcus aureus, but in a case of sickle cell anemia the organism is Staphylococcus Salmonella typhi. Clear? So this is Salmonella typhi, especially in a case of sickle cell anemia. Then at times there is an equilibrium between the two, between the host and the organism, and what we can see a localized lesion. Clear? So it is localized to one part of the body, and it will remain there but without any further enlargement, and this is known as Brody's abscess. Then skeletal tuberculosis, most common site of skeletal tuberculosis is of course vertebra, and the Mycobacterium tuberculosis will travel all the way to vertebra from either lungs or lymph node. Clear? So it starts in vertebral body, especially affecting the thoracolumbar region T9 to L1. Earliest feature is back pain, and if you look at the x-ray, the earliest finding is reduction in the intervertebral disc space. See, this is normal, right? This is normal, but look here, this is reduction. So reduction in intervertebral disc space, or what is known as narrowing of disc space. So reduction. Then coming to rickets, the pathology is that there is defective mineralization of osteoid, and therefore the bones, they remain comparatively weaker. And if such a child starts weight bearing, the legs will bend, right? So we see the deformities involving the knee joint because the bones of the lower limb are not strong enough. Now what we can see craniotabes, that is soft skull bones. We can see wide open fontanelles, and we can see enlargement of costochondral junctions, which is known as rachitic rosary, right? So these are all rachitic rosary. These are painless costochondral junction enlargement, right? So these are painless. One can also see Harrison sulcus, which is the attachment of diaphragm. So this is Harrison sulcus. Okay. Now what is more important in terms of X-ray? We can see widening of growth plate. So there is widening of growth plate, and secondly there is cupping and splaying of metaphysis. So just two things: widening of growth plate, this is widening of physis or growth plate, and second is cupping and fraying of metaphysis. Then osteogenesis imperfecta, this is a condition because of defective collagen and autosomal dominant entity. We can see multiple fractures, and this may be associated with blue sclera because the uveal tissue shines out through the weak or thinned out sclera. Rheumatoid arthritis, the characteristic thing is you can see the symmetric lesions. This is very important. Symmetric, it will look like as if in the both the hands the lesions are same, so that is symmetric lesion. And yes, it is affecting the MCP joint mainly, the knuckles, right? So this is all knuckles. You can see the swelling, at times we see the deformity as well. So it is an entity which starts in the synovium. There is synovitis of the peripheral joints with symmetrical distribution. This is very important. Peripheral, especially hands, metacarpophalangeal and proximal interphalangeal, but not distal interphalangeal. Usually affects females of young age, and it affects MCP and PIP, and the classical word is symmetric arthritis. There are two deformities which one should remember. One is the swan neck deformity, and another is the boutonniere or button holing deformity. Clear? It's just the attitude at the PIP. So this is PIP and this is DIP. So the attitude at PIP and DIP varies. So this is PIP and here this is DIP. Clear? So in boutonniere deformity there is flexion at PIP and there is extension at DIP. In swan neck this will reverse. So flexion at DIP and extension at PIP, and this is the swan neck deformity. So opposite postures at the IP joints. Now extra articular manifestations are more if a person is positive for rheumatoid factor. Then moving to ankylosing spondylitis, which is associated with actually B27, and one of the important finding is anthesopathy or anthesitis, which is actually the pain at the point of insertion of either tendon or cartilage over the bone. Then patient complains of pain at rest, and as he is involved in activities the pain will disappear. So therefore morning pain is a classical complaint, right? So morning backache, because when he'll get up, he'll have severe pain in the back. And what we see classically in X-ray, we will see the classical bamboo spine. This is because of formation of these osteophytes here. So this is vertebral body, and there is formation of osteophytes, which gives rise to the typical bamboo spine. And sometimes we can also see squaring of vertebra. Right? but from exam point of view, please remember bamboo spine and don't mix it up. This is ankylosing spondylitis. Then moving forward to osteoarthritis, which is a degenerative condition where the articular cartilage is destroyed. In contrast to rheumatoid arthritis, which affects the smaller joints, osteoarthritis affects the bigger joints like hip and knee. Hip is in Western population, most commonly involved in Western population, but knee is affected commonly in Indian population. Now it does not affect MCP joint, which is characteristically affected in rheumatoid arthritis. So in rheumatoid arthritis, MCP is the most common joint. Then we can see involvement of DIP as well. So this is one more differentiating point, because no DIP in rheumatoid arthritis, but here we can see involvement of DIP. So this is involvement of DIP, and there is formation of Haberden's nodes. In PIP there is formation of Bouchard's nodes. So these are the nodes at different interphalangeal joints. Now what we'll see on X-ray. Now this is a normal knee joint where we can see joint space, and this is actually occupied by articular cartilage. And when this articular cartilage will degenerate, the bony ends will come closer, and this is appreciated as decreased joint space. Clear? Apart from this, there can be formation of some bony spurs also, like this. So this is bony spur. So on X-rays it is quite easy to identify. So narrowing of joint space and osteophyte formation. Okay, so these are some important points which I feel are very important for upcoming FMG exam. So thank you very much for joining this session. Very shortly I'll be coming with one more subject. Till then, study well. God bless. Bye bye.